So one of the things we looked at doing in some of our projects is basically taking this and saying what domains fall under neurophysiological. Basically saying, what does this mean? Can we break this down a bit? The hope is that it can start reframing that. I think the challenge is, again, taking it to the patient. If they ask, well, what do you mean by this neurophysiological? It means a lot more if you're able to say, well, we know there's some stuff that happens with the nervous system. We're not really quite sure why yet, which of these mechanisms is contributing to your pain response, but we do know this is a useful tool for managing pain, for improving range of motion, and our hope is it allows you, most importantly, to get back to what you want to do.
Damian Keter back on the show.
Nice to see you, man.
To refresh, clinician, researcher with the Department of Veterans Affairs. Thank you for doing that.
Thank you. I appreciate that. Thank you. I love what I do.
I feel like the VA, it takes a bad rap a lot, right?
Yeah, I mean, the challenging thing is it's the largest healthcare system in the United States. And so people, I always tell people, if you've seen one VA, you've seen one VA. It's
right.
not this, you can't take your experience at one and elaborate it to all the others. Overall, I mean, the VA I work at Cleveland, Ohio is wonderful. We see, a lot of patients. We have a lot of awesome clinicians. I would say, from a physical therapy standpoint, our clinicians are the best in the area. And so, from that standpoint, it's what I see is great. But again, that's one facility, one area,
But I mean, from what I've heard, the gripe is typically, I can't get this, I can't get that. But it's the big, as you just said, I didn't realize it, the biggest health system in the country.
Yep.
Of course it is.
Yep.
And it's getting bigger, essentially every day. And geographically,
right.
It's not, there's got to be a center somewhere, right? Yep. Where is the center of the VA? DC?
The DC, yeah. Yeah, DC is where the center's at.
But then it's huge. Yeah.
Right.
It's got to span the country.
Right.
Wow, massive. Give me a ballpark on size. Is there any way to put it in context?
I have no idea, to be honest. I work at one clinic. I know we see a good amount of patients. I don't know what the actual numbers are, though. I couldn't help you there.
We talked last year at AAMT. Your session this year was what? Beyond neurophysiological pain, science, and manual therapy treatment mechanisms?
Yes. So essentially, I'm a co-investigator on what's called ForceNet, which is a U24 on manual therapy mechanisms research. And so we're doing a lot trying to better identify what's happening when we put our hands on patients. A lot of the old narratives surrounding biomechanical changes and stuff like that, it's not gone, but the idea is there's a lot of other stuff going on as well. And so, the idea is we're really trying to frame what are some of these things that occur, what are some of the things influencing these things that occur, looking at contextual factors and stuff like that. And so the more recent paper we put out is I did what's called an umbrella review, an overview earlier this year, which looked to map all of these mechanisms that occur across the neurological domain, neurovascular domain, neuroendocrine domain, all of these things that happen when you put your hands on a patient. And what was wild is it was a review of reviews, and you see this stuff has been well studied, and there's a lot of stuff that occurs when we touch patients, and we know it has a huge effect on clinical outcomes, range of motion, pain, all of these different outcome measures, hence why it's in CPGs and whatnot. I think the challenge is, at this point, figuring out which of these mechanisms actually matter, because, biomechanical doesn't explain it. The research just hasn't said that this is the one thing that's contributing to why people get better, why pain improves, these type of things, but we're not really sure what does explain it yet. And so that's where, our research moving forward is really going to try to map, looking at which one of these mechanisms or which of these mechanisms in combination truly lead to the patient in front of me getting better. And I think me as a clinician and a researcher, I appreciate that on both ends. I appreciate the idea that, from a clinic standpoint, when I get a patient ask me, well, why is this helping? What does this do? Are you popping my spine back into place? And it's like, well, no, but I don't really know why this works yet. And understanding that uncertainty and being okay with it, but also knowing how moving forward we might be able to fix that gap.
Yeah.
So that's kind of some of the stuff we're working on there.
You've even said, it's in your title, beyond neurophysiological. You've said we need to move beyond the word neurophysiological.
Yeah.
What's gotten lost in the translation when clinicians use that term as sort of a catch-all?
So the problem is, what does it mean, right?
Yeah.
So I talked about this in my talk this morning here, is this idea of, you ask people what neurophysiological mean, and they'll say, well, stuff happens. And it's like, there's no description of that. And even when you look in, through AI and you ask what it means, neurophysiological process is a process in the body regulated by the brain. Well, guess what the brain regulates?
Pretty much
everything in the body.
Yeah.
So basically, it's literally saying a process in the body is occurring. So even when you look at PubMed and some of these search engines, and you're able to say, these terms are increasing. You're seeing every year neurophysiological mechanisms, that term is increasing year by year, but yet we don't quite know what it means. And so one of the things we looked at doing in some of our projects is breaking that down and basically taking this and saying what domains fall under neurophysiological. And that's where we were able to get some of this, neuroimmune, neuromuscular, neurological, neurotransmitter, neuropeptide changes, all of these different neuroendocrine changes, and basically saying what does this mean? Can we break this down a bit? And it was really nice because in our review, what we did is after we broke this down, we were able to organize these in a really nice way, and it fit really well under this model. And I worked with a group of content experts across osteopathy, manual physical therapy, chiropractic to develop some of these domains, and it worked out really well. And I think the hope is that it can start reframing that, and it's not wrong. It's not a wrong term, but I think the challenge is, again, taking it to the patient. If they ask, well, what do you mean by this neurophysiological? And it's like, well, so, it means a lot more if you're able to say, well, we know there's some stuff that happens with the nervous system, with the neuroimmune system. We know there's, a lot of neuromuscular changes in how these muscles activate. We know there's a lot of stuff that happens. We're not really quite sure why yet, which of these mechanisms is contributing to your pain response, but we do know this is a useful tool for managing pain, for improving range of motion, and our hope is it allows you, most importantly, to get back to what you want to do. And I think, connecting the dots between those things, we're still working on it, but we're getting there.
That's what you're here for.
Yeah.
Just more research is needed. We've just said it. More research is needed.
Yeah.
In some of the stuff that you've studied, you're mapping out multiple domains of mechanism. If we understood those better, how might day-to-day patient care change if we understood them better?
Yeah, so I think, Corey Simon here at this talk did a really nice job outlining some of these the idea of precision medicine, outlining this idea that if we can figure out more consistently what this patient coming in the clinic looks like and how we can match this to a treatment, to an intervention, that's precision medicine. And so the idea with this, and the example I used in my talk this morning, is this idea is if we can say, okay, for example, neuropathic pain. One of the primary drivers of neuropathic pain we know right now is neuroinflammatory mediators along the nervous pathway, especially with chronic neuropathic pain. We also know that manual therapy, specifically nerve glides and some of that stuff, does well changing neuropathic, neuroimmune modulators along that nerve pathway. We also know that manual therapy influences neuropathic pain. But those dots haven't been connected for us to say, this person has increased neuroimmune modulators along this nerve. We're modulating these with our manual therapy techniques, and that mediates, from an analysis, from a stat standpoint, that mediates a clinical standpoint, the clinical outcome. That's why they get better. Then we can say, if I get an individual with this, I know that I can do this technique, and it should influence this pathway and should get this person better. And so that's where, precision medicine, that's what we're looking for. Is getting away from this idea of it's an anatomical problem, it's an anatomical fix that's contributing to pain, to there's a lot of other crap going on there that all influences that system, and all are things that are able to be modulated by manual therapies and other techniques as well.
Okay. You presented on both mechanisms and education. That's something else that you're involved in. Are we training therapists to understand why manual therapy works, or just how to do it? I feel like it's the former now. I feel like it was just how to do it maybe 5, 10, 15 years ago.
I think it's both, and I think there's a lot of variability in different programs and different philosophies. I think both are obviously very important.
Sure.
And I think the initial school of thought many moons ago was this idea that it was more technique based. You need to spend this time learning the technique. All of the other stuff, it was still involved, but it was kind of the side dish. That was the main course. I think over time we've really transitioned to this idea that it's all equally as important, and those skills are still very important. You need to understand how to use your hands safely, effectively with patients, but at the same time you need to understand what we do know and what we don't yet know. And so, from an education standpoint, we're still trying to figure that out, because if we don't have the answers yet, if we're still doing the research, to try to answer that, how do we teach that to patients? And I think understanding that uncertainty and being able to educate, people we're training, students and fellows and stuff like that, on that uncertainty, but more importantly, getting them to be able to discuss that uncertainty with patients, that's the challenge. But it's nice because when we think about that and we think about uncertainty here, a lot of times people are like, well, no, they want an answer. Well, yeah, but a lot of the things that work, acupuncture, even a lot of medications. If you look at how a lot of medications work, they don't really know. Okay, the mechanisms behind a lot of common pain relieving medications, how they work, they're not sure. And we know that through different sham, placebo type of studies is, the way we thought a lot of these things works is not why they actually work. And so I think understanding that uncertainty, understanding it's not just unique to manual therapy, and being okay with that. We're not gonna understand this stuff. We don't, and we're not going to, and that's okay.
Honestly saying I don't know.
Yeah. I feel like I know nothing, and I'm okay with that. That's fine with me.
You're in the dip of the Dunning-Kruger, right?
Right.
You learned a bunch, and now you're like, oh crap! Now I realize how much I don't know.
Right.
There's a guy. I'm gonna mispronounce his last name probably. He goes by Dr. Mike on YouTube. Have you seen this guy?
No.
He's an ER physician, but he's this big YouTube guy. And he had this conversation where he talked about why a lot of times some people on social media will get these massive followings and make tons of money because they're saying, hey, got headaches? Yeah, then you need pink Himalayan sea salt. And this guy, Dr. Mike, would say, like, But I would come in as a physician and say, well, tell me about your headaches, or tell me about you, or how old are you, or what kind of work do you do, or where are the headaches and when do they come on? It's uncertain. So because I sound wishy-washy because I'm like, I don't know, I sound like I'm less educated or I'm less sure. But really that's what medicine and biology and all those different things are, is we are unsure about a lot of those different things because we've got to ask those questions. But I don't want to label them, but I'll label them sometimes the grifters. The grifters are saying, got headaches, you need pink Himalayan sea salt. And you know what? I'm selling pink Himalayan sea salt.
Yeah. And does it work for some folks?
Maybe.
Yeah, I mean, we know,
Sure.
they've done a lot of research, they've done a lot of contextual factors research looking at these, non-specific effects, and we know for a lot of folks, those expectations, they drive a lot of that treatment
outcome,
effectiveness.
sure.
Some of these say as high as, 80, 90% of the treatment effect may be, and there's a lot of controversy there related to what the number actually is, but might be actually responsible for the clinical outcome. So if I can sell you that snake oil, sell it.
For how much an ounce,
right.
man?
So, but that's where the challenge comes in, is, what does that do downstream?
Right.
If that same patient 5 years later is still doing that same thing and has blood pressure issues but keeps taking salt because they were told that that's the best thing to manage it, then what?
Sure.
And so, I think that's the challenge, I think, is, how do you do this in an ethical way
Right.
without, making things up, but also understanding what we don't know.
And when to say we don't quite understand it now.
Yeah.
But we know that and then you can speak from truth.
Right.
We have seen this be effective in some cases.
Right.
Yeah.
Right.
Being as accurate as you can.
Right.
How much of manual therapy's effects is in the hands and how much is in the context, the communication, the setup, the expectation, something we just talked about in terms of the expectation on the receiving end. So how would you explain that to a student? How much of it is in the context and how much of it is in the hands?
Depends on the patient.
All right, good.
Depends on the patient. Yeah, I truly think, and I think that can be said, again, kind of talking about some of this precision medicine and pain phenotyping, right? When you look at the different IASP, the mechanism-based classification for pain and those type of things, you look at nosoplastic pain, which is ultimately, a central type of process, processing type of issue leading to pain. We know that spinal manipulation still does very, very well with those patients. And we know in those patients it's not a mechanical thing as much. It's more the central sensitization, some of these other, systemic neuroimmune type of things. And so if we're able to fix them and it's not a specific, pathoanatomical condition that's leading to it, it's probably more in the brain, right? It's probably more that neurological type of thing. But if I have a patient that, slept the wrong way and woke up with a crick in their neck, do I think that, me doing a manipulation on that's going to get them better in a lot of cases? Yeah. And we see that where their motion instantly comes back. And in that case, I could probably say there's some tissue stuff going on that these magic hands may have helped with, right?
Right.
So I think it depends. I think it depends on the patient in front of you. And again, when you talk about all these different mechanisms that occur with manual therapy, some of those different mechanisms might be more important in some patients than others, right? Depending on what they're coming in with. It's all about the patient, that individualized care.
Agreed. Let's get back to the VA, work within the VA. What's unique about applying advanced manual therapy concepts in the population of veterans with complex pain?
What's unique to that population?
Yeah.
I don't necessarily know that it's anything, unique to that population, because truly, a lot of these folks want to get back to sports. They want to get back to, the normal things everyone else does. They have different, I don't even want to say different, but they have, some contextual factors. Obviously we know mental health conditions and some of those things we see a little bit more in that population. But, ultimately I think the patient care is very similar to the private sector. We see a lot of the same stuff, a lot of the same goals. I think one of the biggest advantages we have is we don't have the same barrier related to insurance and costs and stuff like that. So I'm truly able to give my patient what they need to get them better, right? Rather than worrying about I have to do what the insurance company will let me do to make them better. And so I think that's really helpful, but I don't necessarily see that as like a difference in how I would treat them.
Okay, all right. If you had to rename manual therapy today based on your findings, based on everything what would you call manual therapy? This is simple but not easy.
It's deep. That's deep. Considering I am a co-investigator on ForceNet, and the NIH has branded manual therapies as force-based manipulation, I'm going to go with that.
Ooh, that's
force-based
smart.
Manipulation. And I think, they went with this term to encompass, all manual therapies across all disciplines. Because I think it's challenging because when you look at, osteopathy and they look at it as osteopathic manipulative therapy or manual therapy, chiropractic looks at, spinal manipulative therapy or chiropractic manipulative therapy. They wanted that term. We use manual therapy in the PT world, but they wanted something that encompassed all those. So I would love to see that all align. I would love to see, us all move towards force-based manipulation type of term, which we've used in a lot of the literature we've published because of those multidisciplinary groups, and I think it does encompass things well. the challenge is if we start doing that, people are going to say, I don't know what that is. I'm not going to read that article, right? So how do you get that to change? But I think it does fit, well for what we do. It's force-based manipulation. That's what we're doing.
All right. Last thing we do on the episode is parting shot. What's an idea or
Whiskey?
concept? We could do that. We're at day 2, at the end, almost the end of day 2 of a 2-day conference, and we're coming across we're finishing strong. I will be doing a shot of something pretty soon. But what's an idea, comment, concept, quote, something you want to leave with the audience as we wrap up?
I think, we know manual therapy is effective. Manual therapy is, highly recommended across clinical practice guidelines. It's something we use all the time. It's something that should continue to be used. We're still trying to figure out why it works. That's pretty much it.
And that's why we need more research is needed. Damian Keter, appreciate time. Thanks for coming on the show again, man.
Absolutely. Thank you.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMT. Subscribe now so you never miss an episode, and connect with us at aomt.org or at AOMT on social. Opinions are those of the guests and not official AOMT policy. See you next time.